And the first speaker is, I don't need to introduce you, Dr. John Etiologies. He's the well-known and the most credible kind of speaker for this kind of talk. John.
Thank you, Mr. Wu. I'm embarrassed saying anything about genetics with Diana Milowitz here, but maybe I can dumb it down for the rest of us, Diana. I'll try to take a common sense look at the genetics of thoracic aortic aneurysm. I'll take a historical glimpse, talk a little bit about how the patterns of family inheritance became manifest, a little bit about the Mendelian genetics, a little bit about the molecular genetics and this RNA signature test that we have, and then a few words about whole exome sequencing. So historical glimpse. The first recognition that connective tissue disease ran in families was probably Hippocrates in his famous thesis on air, fire, and water. And that was in 400 BC when he noticed that the nomadic warriors had lax joints and easy bruisability. And then, of course, the other giants who contributed to the field, Marfan and Ehlers and Danlos. And I want to say a few words about Dave Tilson, who has always been my mentor for my first day as a medical student. In the early 1980s, I remember getting goosebumps being a student in the audience when Dr. Tilson and Dr. Dang presented their work that differentiated vascular disease into aneurysms and occlusive disease. That was a major, major, major distinction that hadn't been previously made. And at the same time, he pointed out there were studies that had shown that abdominal aortic aneurysm was inherited. That was just a landmark presentation that was later published. And Dave doesn't get quite as much recognition as he should for the pioneering work that he did. And then, of course, Lois and Dietz and Diana Milowitz. Much of what I'll show you was discovered by Diana, for whom I have the highest level of respect. And Diana, you're in the slideshow, whether you're in the audience or not. That's not for your benefit. So the way that this hit me over the head like a sledgehammer, that this disease ran in families, was when Marianne and the team and I were making rounds on a 59-year-old woman on whom we had done a type A dissection 3 days previously. And she was well enough to have a conversation. And I said, ma'am, has anybody else in your family been affected by anything similar? And she said, well, doctor, don't you remember you did my mother 5 years ago? And of course, I had no recollection of that. And then I said, anybody else that had anything similar? And that's when she started to cry. And she was absolutely inconsolable. Finally, we were able to get the information out that her little girl was the youngest human being ever to die at our hospital of a type A dissection at the age of 12. So this was 3 generations in one family. And we surgeons were not that smart, but if you hit us with a sledgehammer, we pay attention. And of course, this is my favorite test for inherited connective tissue disease. It's a simple test, it costs nothing, but if you can cross your thumb over your flat palm, there's something wrong with your connective tissues. So we started looking at family trees. And from the first 100 that we investigated, these were the 21 positive pedigrees. And that number has stood true. Now that we're up to hundreds and hundreds of these families, that number has stood true. And the majority of the inheritance is autosomal dominant, with these other patterns manifest as well. And Diana had written a paper showing the exact same number. You can take her paper and her numbers and superimpose it exactly on the paper we wrote a year or 2 later with this 21% likelihood. If the proband has a thoracic aortic aneurysm, there's a 21% likelihood that a family member has a known aneurysm. So the true incidence is going to be much higher because family members, by and large, were not investigated at that time. In this graph, I show you where the aneurysm is located in the family member. In the back row, the proband has an ascending aneurysm. Please note that the family members overwhelmingly have ascending aneurysms. In the front row, the proband has a descending aneurysm, and please note that the majority of the aneurysms in the family members are in the abdominal aorta. And this all goes together with a concept of this disease that it's two separate entities separated by the ligamentum arteriosum. In the ascending aorta, it's a non-calcific, non-arteriosclerotic process, not related to the common risk factors for vascular disease, and thrombus-free. When has anyone seen thrombus in an ascending aortic aneurysm? In contradistinction, beyond the ligamentum arteriosum, it's a disease that's calcific, thrombus-containing, arteriosclerotic, correlated with all the traditional risk factors for vascular disease. So the genetic patterns that we've seen support this view of thoracic aortic aneurysm being two different diseases. So now, largely through the work of Dr. Milowitz, these many mutations that can cause thoracic aortic aneurysm have been identified. This is the list as of a few months ago. It grows several times a year, I would say. From the basic fundamental standpoint, the important thing to note is that this is a dominant inheritance. Thoracic aortic aneurysm, except for the two exceptions that you see there, is inherited in a dominant pattern. Now, why is this important to know all these mutations? We'll hear more from Diana, but there are certain mutations that allow the aneurysm to disobey the usual criteria for its behavior, specifically to dissect at a small size or unpredictably even without an aneurysm. And those are the ACTA2 and the MYLK mutations. So here, we're beginning to be able to treat the disease differently depending on the specific mutation that the patient manifests. And we're excited about this RNA signature test. We've been working on it for a number of years. What I'll show you now, we have replicated in a completely different set of patients, so we feel more confident about it. Of course, the DNA is the blueprint of your body, like the blueprint of your house, but the RNA are the worker moieties that actually do the building and the reconstruction, whether it's the dining room, garage, or other part of the blueprint. So we looked at 33,000 of these, and from those we distilled the most upregulated or the most downregulated from those 33,000. And we created a chip with 41 most upregulated or downregulated RNAs from your peripheral blood leukocytes. And that one test has, as you can see, an 80% ability to predict from your blood whether you have a thoracic aneurysm or not. If all the red dots were in the red 3D oval and all the blue were in the blue 3D oval, it would have been 100% accurate. So now again, dumbing it down for those of us who aren't scientists like Dr. Milowitz, in these hierarchical clustering diagrams, each vertical line is a patient, each horizontal line represents a different RNA. Green is underexpressed and red is overexpressed. So you can see here, if all the blues were together and all the reds were together, the test would have been 100% accurate. It's not 100%, but it's pretty darn good. It was 100% accurate at segregating ascending from descending and familial from non-familial aneurysms. So we're hopeful that this could be a test even for the general population, like a PSA test for prostate cancer. And finally, I'd like to show some work that we've just completed recently on whole exome sequencing in this disease. You know that the first genome that was ever mapped was the president of Celera Genomics. And that cost, I don't know, $500, $600 million and took 5 years. And now we're down to a genome that costs about $1,000. In actual cost, the charge is much higher than that. So sequencing the genome is a possibility. An even cheaper price is very visible on the horizon. So what our team has done is to sequence the coding part, the exome part, through the breaking down of the gene as you see there, and then it's being read. This is the current panel of 21 genes that we use. Again, most of these have been identified by Dr. Milowitz. So we now have done over 100 of these completed exomes. And this is the distillate of what we have found. In particular, I'd like to show you this group who have variants on an aneurysm-causing gene that haven't been previously identified. So out of just over 100 patients, we identified 21 who had new variants that hadn't been previously identified on genes that are known to cause disease. So I think this is very exciting. I think it means that we'll be able to construct and amplify the dictionary that Dr. Milowitz has developed, and we'll probably have hundreds or thousands of entries. And each entry will ultimately be found to have a slightly different behavior than other variants as the cause of thoracic aortic aneurysm, which will permit us to deliver personalized care depending on the particular variant in that patient. And this is an example where we've operated on everybody in this family for aortic dissection. Now that we know that they have this bad behaving gene, we're going to operate on the young person that you see there at the bottom who has not had a dissection yet and has a small aneurysm. But that's the kind of advance that will be possible through this personalized approach. So to summarize, I think we have crossed the threshold into personalized management of thoracic aortic disease. It is financially feasible. This permits the testing of family members. If they don't test positive for a mutation that their afflicted family member has, then you can stop imaging them. The ones who do test positive can be imaged for the monitoring of their aneurysm. This will permit a dictionary or encyclopedia of specific variants that I think will grow to probably hundreds and thousands. So we have crossed over the threshold to personalized management. It's a very exciting time. I'm a surgeon. I love to cut out the aorta, but I recognize that this is where the future is in this disease, for us to understand it at the genetic level, and then that opens whole new vistas for conventional and perhaps genetically directed treatment. And if this RNA signature test pans out, it may provide an opportunity to test the general population. This disease, if we know that an individual has it, we can protect that individual. We won't let anybody die once we know they have an aneurysm. We know approximately when we should operate on them. The challenge is to identify them in the general population, and we may be there as well. Thank you for your attention.